scientists were interested in bipolarity, and the most important work was done in the 18th century concerning classification, but Emil Kraepelin was the most important scientist who we call it cloven peach. His theory before it was described as unitary psychosis, but Kraepel found that it's cyclic and persistent. And there are two different sides of it: manic depressive insanity and dementia precox. Which is more persistent and continuous. Why? So what? It has formed the foundations of our point of view today. He has all classification system we do have now in our diagnostic system of DSM-5. So he starts with at the moment, we have more categories or subcategories in our system. At the moment, there are a lot of pages added. Now you see on the picture of the pages which were added to the new versions of DSM. And new definitions are not very well known, and there are some diagnoses which were added later. So there are a lot of more details which were added, and first you learn the new definitions, and then a new edition comes, and you need to start from the very beginning. But the main question is this descriptive diagnostic validity. Is it valid, really? We say evidence-based, but schizophrenia or bipolar, they are relatively valid. Some of us can say that sometimes there are questions about validity of such diagnosis and its descriptivity. Let's see the descriptive diagnosis. We can say that there are three main categories. So people used to say melancholy, and it was used in very old epics. Or schizophrenia was used to be called insanity. So when we say depression, there is depression. Can be mania in depression. Before we could not say so, but now we can say that mania can be in depression as well. Psychosis, maybe. When we look at bipolar disorder, is there a mania? Yes. Depression, there can be depression as well. Besides mania, the bipolar disorder can be type 1, type 2. There can be depression, can be psychosis. Of course, there can be schizophrenia. Is there a psychosis? Yes. Is there mania? There can be mania. There can be such diagnosis. Is there a depression in schizophrenia? There can be. So we see that if someone has depression, mania, and psychosis, his diagnosis could be depression, bipolar disorder, and schizophrenia. So is this diagnostic validity really valid? So when we look at the psychotic, so let psychotic patients see the validity numbers. They are not really high. You can see on the picture at the table. So when someone asks if bipolar disorder can turn to schizophrenia at some point, we cannot say it cannot, because it can, because there are some certain psychotic features, and the person who doesn't receive necessary treatment may develop something else like schizophrenia. And sometimes a person of 70 years old comes after a lot of episodes experienced. So one of the main problems, do they stay in the same category? In 2011, there was a study in Spain, and the ratio there was 50%. So the person diagnosed with bipolar disorder will continue as bipolar disorder only in 50% of cases. So let's move to diagnostic specificity. Psychotic features can be seen in bipolar disorders, depressive disorders, and personality disorders, catatonic. So when we see catatonic features, we usually understand them, but it doesn't help us to diagnose. Panic attack, like everyone has panic attack. Is it fever? Is it a headache? There are a lot of different features and symptoms. So I usually show it in different presentations. There are measures, as you see on the table. So if we see, like, there are 7 different symptoms, and the person has 4 of them, can be defined according to the literature. So let's not waste time with mathematics. We see in clinics bipolar disorder has 382 different combinations. If there are a lot of definitions about the same disorder, what should we do? So it's kind of galaxy, the same number of combinations. So a person who was diagnosed with one disorder gets another diagnosis in another clinic. So there are a lot of overlaps, and the boundaries are not consistent, or some disorders can transform, and it's not limited. We can develop new modelings, new models of. When I visited Cardiff University, and we can. There was a work about lifelong psychotic patient. So here you see five-dimensional model, and we can diagnose patients according to them, but it's not really practical. So this one was done a long time ago in PowerPoint. So we see diagnostic spectrum and different dimensions. There are a lot of things done according to it. And let's say research domain criteria or hierarchic taxonomy or dimensional alternative to traditional psychiatry. As we are trying to form a genetic basis for this. So we are trying to, we have some ingredients to do this dessert, but the taste remains the same. So what was Kraplin's theory? Sensitivity specificity problems for more complex diagnosis. Sometimes our colleagues work on exams. We always say depression because it's always there. But if a patient has high CRP, then he has infection, maybe. But there are also other versions. When you see all symptoms, so there are high rates of comorbidity in our patients and high rates of NOS diagnosis. So, and there are also problems that are not otherwise specified. So sometimes psychotic patients come whom we cannot define because we cannot find something that suits perfectly and diagnose coefficients. They are not high. Why do I was always asking, why do we say atypic psychosis? Why not schizophrenia? Because it was the era of such diagnosis is past. So we have left this system, and in different countries, different paradigms were offered, and sometimes we had I can say that descriptive classification is over. You see three different penguins. So let's say it's depression, mania, psychosis. And which one of them is not a penguin from these three birds? As we see these symptoms, they look like penguins. But it's a water bird and it can fly. They all look like penguins, although their families are very different. And why don't we have this in psychiatry? Because we have a paradigm like face validity, like it looks like schizophrenia. Then we have before we used to recognize schizophrenia, but then subcultures developed. Then we have criterion validity, like wearing red color. I like wearing red color, but the first there are some symptoms like he has a fever and runny nose. The diagnosis is there. So predictive validity, the generated picture. So these are descriptive systems we use daily. So what don't we have? Construct validity. If you need to find if someone has schizophrenia or bipolar or something else, we don't have something we can trust on. But if you go back to the 19th century, then more than 20% of inpatients were in asylum, and schizophrenia was diagnosed according to the visual impression. And there are a lot of biomarkers which are replicated in works. There are some changeable parameters which we can see in patients. It may some things may happen when the person is stressed or when they are pregnant. Some things can be seen when the person is in mania or in depression. So is it a? It can be sign of depression or it can be sign of addiction or something else. So there are things that we cannot see. There are some shared etiology features, as you can see on the table, and shared genetic architecture. There are genes that are common for different disorders, like there are phenotypes. There are common genes for bipolar and schizophrenia. But as you see, there are genes that are same for bipolar disorder, major depression, autism spectrum, and so on. So we have started working on such genetic reasons, but it's like looking for a needle in a stack. And psychiatric disorders are classically there are a lot of genes that are that determine the person's possibility to develop a disorder. And before the person turns 18, we can find a lot of things. And as you see, we were planning to be in the European Union by 1998, but did we fulfill our expectations? The same question we asked to the psychiatric genetics. And they used to say, give us some blood, we'll find the reason of the disorder. But we can only see that there are some factors that can affect the person's future, but that's all. So the picture of the bipolar disorder. If someone hasn't used any medications, they may have diabetes or hypertension. Let's say it's the first episode and there is a problem in energy metabolism and in the cells which let's see the genetic and environmental risk factors. So there are stress, circadian rhythm disturbances, and they all with autoimmune diseases bring to inflammation in brain and peripheral tissues, which brings you to oxidative stress and apoptotic cell damage. So we can say that bipolar and schizophrenia are brain diseases, and we are sure here there are some molecular changes, inflammation, anatomical changes, volume changes. There are various cortex and other brain changes. And these changes lead to cognitive impairment and sometimes to dementia. It's more than psychiatric. If so, this dementia may happen very early. And here there is staging models for bipolar disorder. One of the scientists who worked on this was Kapczynski, who developed models and did classification. And can we define the initial period of the disorder and lifetime? Let's take our decisions according to the patient's specifications. And usually, when patient stays in remission longer than 1 year, they have more chance for recovery, but otherwise it's stage 2, stage 3, 3.1, and so on. So there is a progressive stage. Well, we say that bipolar disorder can be type 1 and type 2. If there is no mania, there is the type is type 2. So if there can be mania or hypomania, and if you see the symptom severity, it's all statistical. Why it's not higher than 4? So if someone comes and we need to wait until his money is 4 days old, and if it's not, then it's not money, is it? So this classification needs to change, and I hope I'll see it during my lifetime. And my second part of the presentation, challenges of bipolar disorder diagnosis. The measurements are very inconsistent. Do you need to admit these patients to the hospital, because in different clinics or according to different clinicians, admission is required or not required. Sometimes we say that psychotic symptoms are important, but I see hypomanic psychosis a lot, but continue to monitorize this person, to screen this person on outpatient basis. These genes are severe, we say, but no, there is no such criteria. If premenstrual dysphoria syndrome takes 3 days, then we don't need to continue. Why? Why do we say hypomania? What if hypermania? Is there a hyper depression? Why don't we say hypodepression? So these thresholds are very subjective. If I say mania or hypermania, it's more effective than bipolar NOS diagnosis and specifiers. It might be seasonal melancholic or and the last but not the least, family history of bipolar disorder. Is there anyone who doesn't use this factor while diagnosing the patient? It's one of the most important factors. It is important not to create a stigma, but um, I take decisions according to the family history, if there were suicides or schizophrenia and so on. We have to use DSM-5 because it's the only tool we have. It may be better, it will be better, but at the moment we have to use it. Bipolar disorder, from a perspective, it's a kind of rhythm disturbance. It may change daily. Sleep-wake cycle may vary seasonally. Sometimes it's more dominant in different seasons. It may be predominant polarity. It may have rapid cycling. And there are a lot of factors which show that it's a rhythm disturbance because when someone travels, it may show more signs of mania or depression, or sometimes the person who travels overseas may manifest some symptoms like it's related with drug addiction, although they haven't used any drugs. Maybe jet lag, postpartum, sleep deprivation. We may use different kind of treatment for such symptoms. So it's a disorder which continues during the whole lifetime of a person, and clinical picture may vary. So periods can be different, and it may depend on the longevity of the day, durability, and where do we see this in our clinics when season changes? Because right now it's it's spring, and there are a lot of patients who call me all the time. And as linear factor, we can say that it's October, November, December, and spring. So I prefer to see a patient at least 4 times a year, so I can monitor their seasonal changes. Why season is so important? Because solar insulation, I'm not going to give you chemical details, but it does change a lot. This is the map of solar insolation and bipolarity. According to the geographical region, you can see the solar effects. And the consortium I take part in, as you see, there are a lot of regions shown on the map, and all calculations were done according to the certain regions. And here the data was taken from NASA. And there are also some regions may be in the same part, but the data given can be different. So the solar insolation is different. So we can see that different phenotypes can have different factors. Closer to equator, the coefficient is 1, but the if you if you go higher, the ratio changes and the suicide rate goes higher. Or alcohol substance misuse, or younger birth cohort increases. So the risk of young birth increases. And this difference starts earlier. Patients, the greater the annual variation in solar irradiation is, the higher likelihood that the first mood episode will be depressive. So here we see why the suicide rate in northern countries is higher. And why it's so important for us, because when we see the bipolar disorder as a whole, the depression is more visible. As you see, unipolar mania is so little, but here is an Italian study. If it's mania, mania is dominant. If predominant polarity is according to the season when it started, this predominant polarity has two measurements, Barcelona criteria. And when we say that and there is also wider criteria. there is a problem of liberty here. There is also a problem where it will be seen. It's not only about polarity. If if someone had only mania and no depression, we don't know how it's going to develop, how it's going to manifest. So we have variations for treatment. It's not, we do know how to stop mania, and we are effective in this way. Predominant polarity, as you see, systemic review and meta-analysis of 28 studies in 12 countries has shown that prevalence of manic and depressive PP is similar. And depressive PP is common in Europe, while manic PP is prevalent in Asia. And there are a lot of factors contributing to this. In manic PP, we can say that younger age, male gender, bipolar 1 diagnosis, presence of psychotic features, manic onset. So that shows us that the person is going to develop manic type, and depressive PP, history of suicide attempts, depressive onset, higher number of mood episodes. If also temperament and polarity is important. So here we say the predominant polarity and temperament, cyclotimic, dystemic, irritable, hyperthymic, and anxious. If we know predominant temperament, what do we know? It helps us to diagnose, because when we see someone with a dystemic temperament, it's going to be more depressive, and it's it helps us to define subclinic picture. And I'm going to next topic, rapid cycling. It so it's kind of absurd definition, but why do we say absurd? Because last year rapid cycling people who had rapid cycling before had slower cycling last year. So as you see the prevalence on the right, so rapid cycling definition is not very valid in these terms, because it can change. So it can say that it may repeat. Genetic susceptibility. Although we haven't found these genes which cause this, and maybe we will never find them, but disturbance in serotonin and dopamine circuits, and genetic susceptibility, circadian rhythm DX, sleep changes, emotional dysregulation, emotional liability, treatment response, cognitive functions, metabolic changes are all interrelated. And it's not only a disorder which has two polars, mania and depression. So bipolar disorder is a rhythm disturbance. It may be seasonal or may daily. It has more than two poles. It's polypolar. Systemic disturbance. Description should be updated. It must be more whole, and it also we know that now it's related with cancer. So here, that's all I wanted to tell you. Thank you for listening to me.